Of all tumour types, the gliomas are among the most challenging to treat. But at the recent Oncology at the Limits conference in London, Roger Stupp of University Hospital Zurich brought renewed optimism with a new treatment using alternating electric fields. Why is there a need for new approaches in the treatment of this cancer?
Glioma, and notably glioblastoma, are the most frequent brain tumour in adults. It remains a deadly disease despite some progress we made 10 years ago when temozolomide was added to standard radiation. But every attempt to actually further improve outcome failed since. But here we have a complete new treatment modality available, what is called the tumor treating fields. So by producing an inhomogeneous electrical field while cells are dividing, the cellular components, which are charged molecules, will actually move according to the electrical field, and you thus will disrupt the physiological process of mitosis of cell division. And this will ultimately lead to irregular cell division, to cell cycle arrest, and at the very end, apoptosis. So it required a device, and this is a device that is now about 1.5 kilos the patient is carrying around, which is battery powered, and then you have to build up the electrical field on the head. For this we need a completely shaved scalp, and you put arrays of electrodes on, so it's 4 arrays of 9 electrodes each, which are linked to that device.
How important are the findings from the latest large clinical trial?
Adding tumor treating fields in a randomized trial, where actually almost 700 patients were included, showed that there is a significant improvement in progression-free and consistently also in overall survival. We know this data prematurely because the protocol had foreseen an interim analysis when we have mature data on the first 315 patients, and actually it showed that we have an improvement of 2 years survival going from 29% to 43%, or with other words, a hazard ratio of 0.75.
Could you put in perspective this improvement in survival for us?
So we have done, and I've been partly responsible for, a series of randomized trials with new drugs, with intensification of temozolomide, with anti-angiogenic agents like bevacizumab, like selengitide, and all these trials have not produced the evidence of a clinically significant activity. Actually, the hazard ratio in those trials was always around 1, and when here we have a hazard ratio of 0.75. So it's the first trial that showed that we actually can influence the outcome of glioblastoma patients, but we need a complete different approach than what we have done so far.
What is the effect on quality of life?
What the trials have shown that overall it's feasible, and we don't see any undue toxicity. What we do see, however, is skin reaction underneath the electrodes which are put on the patient's shaved head. One issue with quality of life is that this is a device which you have to carry almost 24/7, so actually the most patients carry it for about 18 hours a day, completely movable and so on. So we thought it would influence the quality of life possibly negatively. Overall, it's the opposite what I see from experience, that actually patients are highly motivated and feel that they're doing something for their health. My patients have been skiing, have been doing all activities, traveling with the device. So formal quality of life analysis will take a little longer until we have the full data set on all 700 patients to make meaningful analysis. The patient has to be, and that's probably also true for all treatments we propose to brain tumor patients, still in a reasonably good condition. A patient who is bedridden, who cannot move, what we call the performance status, that's not the right treatment for them. It also need to be able to assure that the exposure to the treatment is long enough. In the clinical trial, treatment was continued all the way through tumor progression, but not even the first progression, but even beyond, when another salvage chemotherapy was given, up to the second tumor progression, in order to assure that patients had long enough exposure and that we could benefit from the delayed effect we see with the device.
Some oncologists have been skeptical of this outside-the-box form of therapy. Do you think they'll be convinced by these new findings?
I think if they care about patients' outcome and for the patients, yes, they will be convinced. I think the patients are convinced, and it's the beginning of a new treatment, not only for neuro-oncology, but we have a new treatment modality in our armamentarium of options for cancer patients.
Will tumour treating fields be effective in other forms of cancer?
Indeed, I think if it works in glioblastoma and in vitro, it had preclinical models has been shown, it would also work on other cancer types. It makes most sense in cancer types where the problem is loco-regional and not disseminated or largely disseminated disease. So ongoing clinical trials look at locally advanced non-small cell lung cancer, the mesothelioma, pancreatic cancer, ovarian cancer. So this is research in progress. I've been working on these projects for now 10 years. And I've been skeptical, as many of my colleagues still are. And I think you need to get hands-on experience to see how actually it works. I've been impressed by what I've seen. I've been impressed how patients can manage it. But I also saw that patients are sometimes fed up with our treatments, even the so-called well-tolerated. Some patients were more than happy when we replaced temozolomide by tumor-treating fields, even though it meant carrying a device. It also showed that we need to engage patients and their family members much more in the care. I think that is important also when we go forward with new treatments, when we aim at better quality of life, at longer survival, but actually longer survival with good quality of life.